Any questions from anything we covered last time? Nothing at all. Anyone remember what we were even covering last time? We started talking about kidney stuff. We're going to continue talking about kidney stuff. And this is the last section for the test here. So we'll have it today. Our last class session before the test, it'll be Thursday, and then the test will be Monday, right? So this will be the end of the material there. I'm hoping I can get through as much as I can, and then might have a little bit of material to cover Thursday, and then we'll have the review. So we'll go from there. To start off with, though, does anyone know what you call it when a witch only eats sand? No, it's malnourishment. Not a balanced diet. Anyway, okay, so we talked about pre-renal acute kidney injury. Anyone remember what the most common cause for that is? Dehydration, right? So hypovolemia is a typical cause for that. You're underperfusing the kidneys. Anyone remember any drug-related causes for that? NSAIDs, ACE inhibitors, diuretics, right? Anything decreasing blood volume could be doing that. Anything that's decreasing the actual kidney blood flow or impairing that filtration is going to be causing potentially a pre-renal sort of kidney injury there, right? We talked about intrinsic kidney injury. There's a lot of drugs that can cause that. We'll talk more about that, but that's like your aminoglycosides, that's your contrast agents, the really hyperosmolar contrast agents, things like amphotericin B. Anyone remember that drug? What do we use that for? Really invasive fungal infection, right? We call it amphotericin B because of all the really bad kidney effects that it has, including a lot of intrinsic damage, causes a lot of electrolyte wasting, etc. And then we have some post-renal kidney injury. This is probably the least common one you're going to run into. And again, it can happen anywhere, right? So it can happen all the way through the urinary tract. And it depends on kind of what's going on, what's obstructing, that urine flow. So, it could be, say, due to myoglobin precipitating out in the renal tubule due to, say, rhabdomyolysis secondary to malignant hyperthermia or amphetamine usage or something like that. It could be crystalluria that's caused by acyclovir in a dehydrated patient crystallizing out. Could be, any other potential causes? Maybe I give a leukemia patient a chemo agent and I lyse all those cells open and I get tumor lysis syndrome, right? You have uric acid that's precipitating. There's lots of causes for there, but it's going to be one of the less common ones you're going to run into. But just know there are several varieties that are out there. One thing I run into pretty frequently is the oxalate crystal deposition. One of the things we'll find if you ever have anyone who drinks radiator fluid, right? So again, it's one of those things that's called a toxic alcohol because it gets converted to a lot of really nasty acids that are pretty toxic to the patient, and they actually can develop kidney injury mainly due to the fact that all those oxalate crystals will crystallize out in the renal tubules and cause more of a obstructive or an interstitial sort of damage there, depending on kind of where it's at. But anyway, so those are some common causes there. And again, drugs with poor solubility are the most common thing. And how would you manage that, do you think? More hydration, right? So again, if it's because they have poor solubility, well, I can either try to increase the volume that I'm trying to dilute the drug in, right? So I give more actual fluid, or potentially I can give it something to make it more soluble, right? So in some cases like methotrexate, what can I give to make that more soluble? You guys remember agents we would give along with methotrexate to prevent renal injury? Bicarb, right? So we would alkalize the urine, and that would make it more, raise the pH, would make it more alkaline, and that would make it more soluble. And so that way you'd actually find that it would not precipitate out, right? So that way it would be more soluble, it'd just get excreted through the urine there. So lots of little ways we can do it. Most of the time it's going to be hydration. In some cases you might find that alkalinization is going to be the thing that we can do to increase the solubility. Do we ever try to purposefully acidify the blood? Not typically, right? There's too many other kind of problems you'd run into with that, so we don't do that, right? But typically alkalization is pretty well tolerated. We can do that occasionally. Anyway, so again, their clinical presentation, these are all things you've kind of covered before, but obviously if they're looking at things like changes in urinary habits, if they're obviously not going to the bathroom as often, if they have sudden weight gain, if you're looking at like a small child, like how often are you changing their diaper? It's like, oh man, I went all day and I didn't have to change a single dirty diaper. You're thinking, that's awesome. Usually not, right? So you always want to make sure they're wetting their diapers like they should. And then you have to kind of determine, is it more of an acute problem, right? Did it just kind of happen immediately? Is it more of a chronic issue? It's been going on for a while, or in some cases you have patients with chronic issues, they have an acute issue on top of it, right? So if you have someone with, say, chronic kidney disease and they have an acute bout of dehydration due to gastroenteritis or something on top of that, right? So those are things you have to consider there. And typically, if it's on the inpatient side, if they didn't come in with it, it's easier to determine because we have kind of more total control over what's happening with the patient than if they were coming in from the outpatient side and we kind of don't know what's going on with them. So, and obviously, as far as history goes, look at any other chronic conditions they have, look at their medication history, and then lab studies are going to be really useful here. So the main labs we're going to be looking at are what? To assess kidney function, we're looking at Viewing creatinine, so again, you get that off of a basic metabolic panel, your Chem7. That's also good because I can tell you what else. Your sodium, your bicarb, I can see if they're acidotic, you can see what their potassium's doing, right? Because typically if renal function goes down, potassium is going to go up, right? You're going to find that in some cases it may not always be true, but that's usually what you end up seeing. And then, looking at things like surgeries, procedures, sometimes you can end up developing kidney injury secondary to, a recent procedure they had. Maybe they got hypovolemic, maybe several things could happen. And then obviously you want to check out other things like over-the-counter products you might be using, herbal products, recreational drugs, right? And again, how often are patients going to be totally truthful with you as far as their recreational drug habits? Not great, right? Some people will be pretty forthright with it. They're like, yeah, I was doing some amphetamines. Cool. Other people are not going to have that history, right? So that's where other lab studies can be useful. So something like urine drug screen could potentially be useful there. They're giving you a clue as to what else the patient might be exposed to. Okay. If you had a patient who you're considering they might have like illicit substances, maybe prescription substances they were abusing, and they were really telling you suspected they weren't really being truthful with you. Is there any resources you could use to figure out what they've been filling? Remember that E-Force, right? You can always go back to E-Force and check to see if they're filling any narcotics anywhere. And the benefit of that is you can call those pharmacies, and if they're filling their other chronic meds, you can probably call them and get that information too. All right, most Walgreens, CVS's are all interconnected, so they can, if they fill at any Walgreens, any other Walgreens will have that information that's available. So that can be a useful source of information. And then obviously you're looking for trends as well. Again, a single data point may be able to tell you something, but I'd like to look at trends as well. And additionally, if you're assessing a patient, and we see this all the time, we have a lot of our CF kids, right? Our CF kids will come into the ER, usually have some sort of pulmonary exacerbation, they get dehydrated, they come into the ER, and then we're starting them off on a bunch of antibiotics. One of the things you have to look at is look at your renal dose adjustments. But you don't want to go off of the first set of labs because we know they're dehydrated, so typically their BUN and creatinine are going to be elevated. We'll give them some fluids first and then see how that levels are trending. And once that turns back down to what their baseline is, by looking at previous labs, we know what their baseline is. We can then say, okay, here's how we're going to dose our drugs. Because again, if you were to say, based off that first level, you may find that you're dosing less aggressively than you need to. And what do we know about CF kids? Their pulmonary infections are usually pretty easy to treat, tough to treat. Very difficult to treat, right? Because they have that nice, thick, tenacious sputum is holding in all this mucoid-producing Pseudomonas and all that nasty stuff, right? So that's something we have to consider, right? We run into that every day. So as I mentioned, serum creatinine has, it's one of the best markers we have to check for glomerular filtration, right? We use it as a surrogate when we put it into our calculations for, with Cockcroft-Gault or MDR. If you're doing it with kids, you're using the Schwartz equation, whatever you're using. But there are limitations to it, right? So like in kids, especially like in, say, the first couple of days of life, what's the limitation of using serum creatinine to estimate renal function? Yeah, it's falsely elevated because you actually measure mom's serum creatinine. It takes a few days for that to clear out, right? For instance, what if I had someone who had an amputation? How would the serum creatinine be reflected? Falsely low, high? Falsely low, why? They have less muscle mass, right? Less muscle means you can't produce as much creatinine. And again, I'll find like little ladies or little gentlemen who will be, have almost no muscle mass left, right? They're very, very small, very thin, and they will have a serum creatinine that looks almost completely normal, right? It's like 0.8, 0.9. And I'm like, wow, the renal function must be really good. And then you say, wait a second, I actually have no muscle mass left. The thing is that it's probably more elevated than what it actually looks like. So it's falsely lowered in those cases if you have less muscle mass than you would expect, right? So in some of those cases, right, if I have like a little old person who I suspect has very little muscle mass and they have like a creatinine of like 0.7 or 0.8, I'll usually just bump it up to 1 just for my calculations, just to give myself a little bit more of a kind of a buffer area, right? Because I'd rather be a little bit more, a little bit more cautious with the patients than not. And so, based on that, you can see the calculations will under or overestimate GFR. Take, for instance, when we looked at the Cockcroft-Gault equation, if you remember, serum creatinine was in the denominator. We had the age of the patient factoring in. You also had the weight of the patient, right? So what would happen if I had a really exceptionally obese patient that I was dealing with, say they weigh 400, 500 pounds, right? You run into those patients occasionally. How do you think that would affect the GFR? Falsely elevated, right? So again, is all that weight actual functional weight? No, right? So that's where sometimes we have to use things like adjusted body weights, right? I'm not going to get into the calculations specifically here, but you want to look into things like adjusted body weights to try to get them a little bit closer to what their ideal is when you're doing your calculations. So that way you're not assuming that all of that weight is actually actual functional body mass, right? Anyway, and then you'll find that just like anything else, serum creatinine has a half-life. It takes time for it to get to a new steady state. So you're going to find that typically when you have someone has an acute kidney injury, it takes time for the serum creatinine to reflect that, right? You'll have the insult that occurs here. You say, yo, your kidneys stink. And start holding them, right? Insult. Anyway, so let's say you have an acute kidney injury, you're going to find it takes time for that serum creatinine to go up, and then that will take time. Even though the GFR went down immediately after the insult, it's not reflected in the serum creatinine until several days later, okay, when you actually do your calculations there. So in those cases, what can I do additionally to look at to see how the patient's kidney function is? And measure. What do the kidneys produce? Urine, so I can measure the urine output, right? So looking at urine output, that can be another useful tool. Oftentimes that will be reflected much more immediately than I would see with, say, serum creatinine. So if I'm monitoring a patient, say I had them on vancomycin for a gram-positive infection, say they have meningitis, and I'm treating them for vancomycin. They become septic, they start getting hypotensive, I know they're underperfusing the kidneys, that causes an injury. It may take a few days for that serum creatinine to go up. So if that was the only thing I was looking at, that would be kind of behind the 8 ball, right? Those levels of vancomycin would probably be gently building up as time goes on because they're not clearing it as well. However, if I'm looking at urine output and that drops precipitously, then I know, wait a second, the patient's not processing this appropriately. Let me go ahead and check another level of vancomycin, see where it's at. If it's too high, then I need to adjust. Okay, so those are things you want to be looking at, using those both together to give you a better picture of what's going on with the patient. So anyway, so with acute kidney injuries, if they can be predicted, they can be potentially avoided, right? So prevention is always a little bit better than trying to find a cure there. That means if you're having a patient with, say, major surgery, or say, for instance, they're going to get some high osmolarity contrast dye, you can try to hydrate them beforehand. We do this a lot with our chemo patients as well. We're worried about that tumor lysis syndrome. We're giving them a ton of fluids beforehand, and throughout the chemo, try to keep them hydrated, keep the kidneys perfused, and keep them everything flushing through there. And again, just in general, at least 2 liters of fluid a day. Generally, when you're looking at like an adult patient for those maintenance fluid rates, right? We talked about 125 mLs an hour being typically a good adult maintenance rate. If you multiply that by 24, does anyone know what that turns into? It turns out to be 3 liters, right? So 2 to 3 liters a day is generally pretty good fluid intake for most patients with a good, healthy urine, kidney function there, right? Obviously, if we can avoid nephrotoxic medications, that is preferable. Is that always going to be possible? No, if I have a patient who's growing Pseudomonas that is only going to be sensitive to cefepime and amikacin, I got to use that amikacin, right? I got to use something that's going to be able to get that Pseudomonas, right? So those are things where sometimes you have to use a nephrotoxic meds, but you try to use techniques to avoid any further injury if possible, right? Again, look at those patients who might be at risk, look at urine output, look at the serum creatinine, look at those trends, right? So if a patient comes in with a serum creatinine of 0.6, I don't know if that's their normal or not, right? You can look back in the past to see, okay, well, normally they run at 0.3. Okay, well, that's obviously elevated, right? Versus they're normally 0.6, 0.5. I know that's their normal for them, right? And again, try to implement those preventative strategies whenever possible. As I mentioned, hydration is going to be the one thing that consistently shows benefit in trying to prevent acute kidney injury. We'll talk about a few other drugs we'll try to use, but this is really the best thing you can use, right? Now, we have 2 varieties, and I'll probably mention this before. We have crystalloids and we have colloids. What's the difference between the 2? Yeah, you can think of colloids as typically having some sort of protein base or something that is non-salt based, right? So when you say crystalloid, basically I'm talking about any kind of salt-based products. That means sodium chloride, that means lactated ringers, that means you can add dextrose in there too, that's fine, but really it's going to be that salt base. That's what's providing the osmolarity. Versus with colloids, you're going to find this could either be certain starch-based products like head of starch. So you can have albumin. Albumin is probably one of the more common ones you're going to run into, right? Albumin is good because it provides what kind of pressure? Oncotic pressure, guy, right? You have a test on that recently? Yeah, it's a very important concept, right? So anyway, but typically what you're going to find is that crystalloids are good for 99% of cases there, right? So you're going to find that normal saline, lactated ringers is going to be fine. If you work in surgery, you're going to see a lot more lactated ringers. If you work anywhere else, you're going to see mostly sodium chloride you're going to be using there most commonly. And what's when we consider normal saline, what concentration is that? 0.9% sodium chloride, right? And so again, that is the most commonly recommended for intravascular volume expansion, right? So we're trying to get that extra intravascular volume picked back up, trying to fill the volume of that hose, right, of our blood vessels. This is what we're going to use. Colloids, as I mentioned, tend to be more expensive. Some of them can actually cause renal dysfunction, which can be a problem, right, in some cases there, and generally not needed, right? However, if I have a patient who I know has low albumin levels, right, so maybe they have long-term hepatic disease, maybe they have long-term malnourishment, and I know that their intravascular volume is depleted because they don't have that good oncotic pressure, that's when I can give albumin. That's when I can try to give and replace that to get that pressure back up. We'll talk a little bit more about that a little bit later on, but again, generally, crystalloids are going to be your #1 stop for most of this. Okay. So again, as I mentioned, why is 0.9% sodium chloride considered normal, right? Well, 0.9 grams per 100 mLs is what that percentage means, okay? And if you actually work that out, it means it's 154 milliequivalents of sodium per liter, okay? And again, looking at normal serum osmolarity, 275, 295, right around 300. If I were to take this and I have 154 milliequivalents per liter of sodium, that also means that of chloride I have how much? 154, right, because it's one sodium to one chloride. When that breaks apart, I'll have 154 sodium, 154 chloride. Both of those provide osmotic pressure, right? Provide osmolarity, and that equals out to be what? 308, right? So it's pretty close to what our serum osmolarity is, which makes it hyper, isotonic, right? So normal saline is considered to be isotonic. Very good for filling the intravascular space. We'll talk about free water a little bit later. This has zero free water. The majority of what you put into the patient's veins is going to stay in the intravascular space for the most part. And again, normal serum sodium is 135 to 145. So if anything, if I were to continuously give normal saline to a patient, what would happen to their sodium levels? You think theoretically it would go up, right? And typically you would see that over a long period of time. Normally we have enough compensatory mechanisms where that does not happen. But you're going to find that it could be a case where we could find a mild hypernatremia that could occur from that. Okay, we'll talk much more about water balance and sodium balance a little bit later. As I mentioned, you can give dextrose 5% in water, which is still considered isotonic, right? It's 253 milliosmoles per liter, but we consider that free water. And basically what that means is that dextrose gets metabolized pretty quickly or shuttled into the cells. Whatever happens to it, it's gone basically. All that water's left over, right? So where does all that water go to? Well, it wants to go, because it's very hypotonic, it's just free water, right? So it wants to go to where all the solute is, which means it's going to go out to the interstitium and then go into the cells, right? So again, you can find an expansion of the intracellular volume when you're giving, or the intracellular volume when you're giving this free water. So typically you don't give D5 by itself, especially for like maintenance type fluids, right? Or especially if you're trying to expand the blood volume, you're not going to give this by itself. Now, if I needed to give someone extra dextrose because they're hypoglycemic, then potentially this could be beneficial, right? Usually we use D10, D25, D50 for hypoglycemia, but D5 is usually going to be added into something like normal saline, and that will be good for, especially for patients who are NPO, because again, if they're not taking anything by mouth, we got to give them some sugar, right? Still need some energy to run, and so that's where we can get some of those calories from. All right. So loop diuretics. So what could be a potential benefit of loop diuretics in these patients? And so you would think, okay, well, if the kidneys are potentially being underperfused, I'll give something that will help them to perfuse more fluid through it, right? What would be the downside of a loop diuretic, though? You lose some sodium, lose some potassium. What else? You're also losing fluid, right? So again, if I lose enough fluid, if I have too much loop diuretic on board, that can induce what kind of kidney injury? Pre-renal, right? So again, you're kind of cutting yourself off at the legs there a little bit, because you can use that to help keep the kidneys perfused, but you're going to be losing that fluid there in the intravascular space, and that's not going to be good in the long run, right? So sometimes you may see the two used together, fluids plus a loop diuretic, but again, it's going to be much more on a case-by-case basis, and typically you will not see loop diuretics being used to prevent acute kidney injury, because we know that they're going to be a risk in causing that in the first place, right? So again, typically we don't use that. Again, it's a risk for ototoxicity. If you remember some of the antibiotics that cause ototoxicity, what did that include? Gentamicin, so your aminoglycosides, and vancomycin, right? So again, adding this on top of that could again increase your risk for ototoxicity. So again, this is not great for helping to keep those kidneys perfused. However, what is it good for? Patients who are volume overloaded, right? So if I have someone who has cirrhosis and they have huge ascites, or they have CHF or something, this is where your loop diuretics can come into play there. Again, you're going to lose some sodium along with that, but the increase in volume loss is going to be beneficial to try to get all that extra fluid off the patient there, okay? So that's really the main benefit there. Not good for preventing AKI, but it's good for getting rid of that extra fluid. We can potentially use vasodilators. So if we think about, keeping those kidneys perfused, well, what if I could dilate the vessels down there to try to keep more blood going into the kidneys, right? Just like NSAIDs decrease renal perfusion. What if I gave something to try to increase that renal perfusion? And we have two drugs we can use here. So either dopamine or you have phenoldiprine. Dopamine's kind of interesting because if anyone's used dopamine before, right, what does it normally do? Vasoconstrict, right? So you're thinking, well, wait a second, how is this going to cause increased renal blood flow if it's normally a vasoconstrictor? It's normally a vasopressor. We use it to keep people's blood pressure up, right? Well, actually, it depends on the dose you're administering. In very low doses, you're going to find this actually will stimulate some of these dopamine receptors on the kidneys and will increase blood flow there, right? At higher doses, you're going to find it has much bigger effects on the beta receptors and on the alpha receptors, so you're going to find increases in cardiac output. You'll find increases in systemic vascular resistance. Not really great at helping with the kidneys. Because again, if you think about it, if I give a vasopressor or something that's going to be constricting blood vessels, it's preferentially going to send blood to which two organs? The brain and the heart. Kidneys is not one of those two organs. So again, you can find that with vasopressors, kidney injury is a potential sequelae of that, right? You can find that by giving too much vasopressors, that will decrease kidney perfusion, and that can be a problem. You see that very frequently in septic patients who are either very leaky capillaries in the third spacing, a lot of fluids, very hypotensive. We'll give them vasopressors to get that pressure back up, and we'll find secondary kidney injury because they're not perfusing the kidneys preferentially. Okay. So anyway, so dopamine can be potential use for that. Not used very frequently though. Another drug you may see used occasionally is called phenoldiprem. This is another dopamine 1 receptor agonist, can help to provide a little better kidney blood flow, but again, not great consistent benefit. Again, just giving them fluid is typically going to be more beneficial, cheaper than using one of these drugs here, right? I'm showing you these because, again, a lot of them don't have good consistent evidence behind their use. You'll still see them used occasionally, depending on the doc, depending on the situation, depending on what they're doing. So what could I do potentially to try to stave off some of this, say, interstitial damage, right? So maybe I can use something like, antioxidants that will help to decrease the injury that's being done by some of these products here. And so there's a couple ones we can try using, one of which being ascorbic acid or just regular vitamin C. We can administer that, and that's trying to decrease the oxidative stress, especially seen with those ischemic reperfusion injuries, right? So typically what you'll find is that when you have an area of tissue that is ischemic, or say due to hypoperfusion, or say due to some of this interstitial injury, you're going to find that as you start to resupply oxygen back to that tissue, you can find those generate free radicals. We know that causes a lot of cellular damage. The idea here is by giving an antioxidant, you try to mitigate some of that. Vitamin C has been used. Again, what's the downside of too much vitamin C? Not really. Not a whole lot, right? So vitamin C is very, most of you guys probably drink those Monster Energies, say like 9,000% vitamin C or something. Like you can get a ton of vitamin C. It's a water soluble vitamin, so you get too much of it, what do you do with it? Pee it right out, right? So generally not a problem, right? So again, it's relatively low cost, relatively low side effects. You can try it, right? And if it doesn't work, whatever. Another drug here, we have N-acetylcysteine. Anyone know what we normally use mucimist for? Tylenol poisoning, yeah, I put it up right on the slide there, so that's a free one. Yeah, so Tylenol poisoning is a very common thing. That's where I use mucimist most frequently, but it's a very good free radical scavenger. So in some cases where you have really high risk renal patients who maybe need to go, in the case I always think about is this one time in the peds ICU, we had a patient who had chronic kidney disease, the renal function had really taken an acute hit, but we needed to get them a CT scan, right? And some other concomitant disease state, they needed a CT scan, and so they needed contrast. And so we know the contrast is nephrotoxic, and so the nephrologist was there talking to the intensivist and said, well, let's try giving some N-acetylcysteine for the free radical effects, and let's see if we can go ahead and try to mitigate that. And see, again, we don't have great evidence to show that yes, this 100% works, but low potential risk, only can see some benefit, so we went ahead and did it anyway. Does anyone know what N-acetylcysteine smells like? Smells like rotten eggs. There's a lot of sulfur in it, and so that's part of how it's a good free radical scavenger. It's also why it helps with the sulfation pathway in the liver, but it smells just like rotten eggs. So if you ever get to see like a Tylenol overdose patient and you smell that rotten eggs, it's not the patient, it's the actual mucimist we're giving them to drink, right? Hopefully it's in the IV so that way you don't have to smell it, but my first role as an intern in a hospital pharmacy, they said, oh, because sometimes we'll also use N-acetylcysteine as a mucolytic. Sometimes we'll use it as an inhaled form, so that way it will help to break up mucus in respiratory patients. And so my first job as an intern in the hospital, they said, okay, you get to take this big vial of mucimist and you get to spread out into these little vials for the respiratory therapist. So I got to sit there and smell it for an entire summer, just putting stuff from a big bottle into a little bottle, right? So. And I basically grew numb to it. I can't even smell it anymore. Now it just smells like regular eggs, which is bad because now I can't smell if eggs are actually gone rotten anymore. So that's what it is. Anyway, and again, when you're actually treating the acute kidney injury, so let's say the actual injury has occurred here, the best thing you do is try to eliminate the actual insult, right? So again, if the issue is hypoperfusion of the kidneys, well, let's try to perfuse it more, right? If it's dehydration, give them more fluid. If it's a particular drug, try to get them off the drug if you can, right? That's kind of the pretty straightforward thing to do. And otherwise, you're doing supportive care, right? So you're monitoring fluids, you're monitoring their electrolytes, you're looking at replacing those if need be, or maybe restricting them if need be. And then we can consider things like renal replacement therapy, right? So basically, it's dialysis or various forms of dialysis. Again, you can do a whole course just on different types and modalities of dialysis. But basically, what is dialysis? When I say renal replacement therapy, what is it what's it doing? Yeah, it filters the blood, right? It takes the blood out of the patient, filters it. They'll have a dialysis membrane where basically it uses different pressures to try to force waste products and excess electrolytes and things like that into the dialysate, and then it's going to be able to funnel that back into the patient, and then now they have cleaned up blood, right? So basically it's an artificial kidney, so to speak. And so in some cases, you have to put patients on that temporarily to give their kidneys time to kind of recover on their own. Again, some cases you may find you get full recovery. Some cases you might not be able to find that at all. I've had some cases of patients who are abusing, you remember when like bath salts kind of became popular for a little bit there? It's good, not many of you shake your head, right? Bath salts are very bad news, right? The ones that did shake your head, yes? I'll have some questions later. But it's one of those things where actually they would get this very like hyperthermic encephalopathy that developed, and they would develop rhabdomyolysis, and a lot of them developed kidney injury, and some of them had to be dialysis dependent the rest of their lives, right? So it's one of those things where once a kidney injury occurs, sometimes it may not be reversible there. But and again, our goals here: minimize the insult, try to reduce any extrarenal complications, and then hopefully you can try to recover the kidneys a little bit faster. But most of the time, it's just tincture of time. It's going to fix that. You have to give them time for the kidneys to recover. So, as I mentioned, with dehydration, the best thing we can do is to give them fluid therapy. So either oral if they can tolerate it, or if not, then we'll switch over to IV. That's why I always like working in the pediatric ER, because what is our anyone know what we use for our PO challenges in the ER? We use slushies. We have slushy machines right there in the ER. So we have blue slushy, and we have like a lemon flavor slushy. And so you always tell when the staff were abusing the slushy privileges because they would all have a big blue mouth. They said, can't do that anymore. You gotta stick with the lemon, if anything. But it's good, right? Because it was cold, and kids liked it, and basically just sugar water essentially. But it was good to try to get some oral fluids into the patient there. If that's not possible, then we like to use isotonic IV fluids, right? It's going to be the number one thing to try to replete the intravascular space, try to fill that back up, so that way that we can perfuse the kidneys a little bit better. And again, a normal bolus for normal saline, typically 20 mLs per kilogram. Again, that's going to work for just about anyone. Usually for adults, that will cap out around 1 to 2 liters, right? Now, obviously, there's some cases where you have to give massive amounts of fluid far well and above that. So if you think about trauma patients who have massive bleeding, things like that, maybe giving 6, 8 liters of fluid. But for most adult patients, start with 1 liter to 2 liters, and you're going to be good, right? Sepsis is another case where you might have to give a ton of fluids to get them, because their vasculature is so leaky, their third spacing a ton of fluids. You have to give them a lot to try to replete that. And usually your goal, try to get their MAP above, say, 65 or so. And how do you normally measure MAP? So you can read it on the monitor, right? I'll just tell it to you, but how does it calculate that normally? So again, you think about, you spend about 1/3 of your time in systole and 2/3 of your time in diastole. So it's 2/3 of your diastolic plus 1/3 of your systolic. Add those together, and it should be around 65 or so is a pretty good goal to shoot for, right? And also you're looking at urine output. We like things above 0.5 mLs per kilo per hour. For kids, we like to see above 1. But again, that's usually kind of our goals we're shooting for there, right? And obviously you're looking for other things, right? You're looking for signs of volume overload, right? You're looking for signs of edema. You're listening to the lungs to see if you're starting to fill up the lungs there with fluid. You're looking at glucose, you're looking at electrolytes. So your basic metabolic panel can be really useful from that standpoint, right? Now again, if the patient is anuric or oliguric, you're going to be using smaller volumes. So again, with fluid, the thing is that you can always give more fluid. It's hard to take it back off, right? Because again, what's the only ways I can get rid of the fluid? Well, if they're anuric, I can't expect the kidneys to do it for me, so it's the only other way I can do it. Bleed them out. So I'm just going to cut this jugular here and just see how good. No, basically you put them on renal replacement therapy, right? So you'd have to use a dialysis machine to pull that extra fluid off, right? That's not ideal in a lot of cases there. But consider that, if they have CHF or pulmonary insufficiency, they tend to hold on to more fluid there as well. So that's another case where you might want to be a little bit more, careful with how much volume you're giving there. Now again, one risk if you're giving a ton of NS, you can end up seeing this hyperchloremic acidosis, because if you go back to your basic metabolic panel, we said, a normal serum sodium is about what? 135, 145. What's a normal chloride? Usually like in the 110s, 110s, somewhere around there. And if you think about it, if we're giving 154 milliequivalents per liter of sodium, that means we're giving 154 milliequivalents per liter of chloride. You can end up seeing this hyperchloremic acidosis. Usually not too big a clinical concern, but in those cases there, you could potentially switch it out and maybe give 0.45% sodium chloride, and you can actually make up the rest of that sodium with sodium bicarb potentially, right? So that's one thing you can use to get around that. And then also as well, their patients are anemic, especially due to trauma, they have massive bleeding. This is where blood transfusions are also going to be able to provide that volume as well. As I mentioned, renal replacement therapy, it can either be an intermittent in nature, meaning they're going to be getting it, say, for a few hours at a time at various times, or it could be continuous. And so I see this more in the ICU setting, where they're on continuous renal replacement therapy, or CRRT, if you ever see that. That means they're basically on this machine 24/7 that's working for their kidneys. Once they're on the outpatient side, that doesn't really work anymore. You have to use more of the intermittent. So that's where you see a lot of kidney patients who are on dialysis on Monday, Wednesday, Friday. Invariably, they miss their Friday appointment and they end up coming in volume overloaded, hyperkalemic on the weekend. That's where I see them in the ER. But the main indications for initiating hemodialysis includes acid-base abnormalities. Usually, a patient, if they are acidotic, is a more common cause for needing dialysis there. They have an electrolyte imbalance. What's the main electrolyte we can pull off with dialysis, I think? Potassium is a big one, right? So we can use potassium to help use dialysis to get potassium off potentially. Intoxications, there are several drug overdoses we will actually use dialysis for to pull the drug off of the patient. If their kidneys are not sufficient to get rid of it itself. Anyone know any examples? I've probably mentioned them before. Lithium is a good one. Aspirin's another potential one. Toxic alcohols, if I had someone who ingested like radiator fluid or windshield washer fluid, it's another one where I can potentially use dialysis to pull the drug off the patient before it has a chance to really cause any more havoc for them. And again, that can be a very difficult conversation to have, especially in the middle of the night. Someone drank a bunch of radiator fluid, they're out in the panhandle, and I have to tell them, hey, you got to call the on-call nephrologist to come in. And they live an hour away, and now they got to drive in to put a dialysis catheter in this patient. It's a tough conversation, right? They're going to say, I'll just wait till the morning. Like, patient will probably be dead in the morning, so let's try to get this started up now. And so I've had a few arguments over the phone like that before. But fluid overload is another big thing. So again, I can pull extra volume off with a dialysis machine, and then uremia is another one. So again, helping to filter the blood, get rid of some of the extra waste products. And so again, the helpful mnemonic to remember those indications is basically just the vowels. You will leave white off, but those 5 are the big ones we'll use most frequently. So looking at pharmacologic therapy, again, consider what happens during acute kidney injury, what changes are occurring physiologically. So for instance, what do you think happens to volume distribution, say for instance for, say, a hydrophilic medication? Patient's kidney function goes down, they're holding on to more volume. Should increase, right? Because now you have more space for that drug to partition into. So my blood levels will go down because the drug is now partitioning out to the extra space, right? So partitioning out to that extracellular fluid in the interstitium. Look at the volume stats of the patient as well. Again, the more edematous they are, potentially the more likely you have that increase in volume you're going to see there. And again, antibiotics have to be dosed especially carefully in septic patients, right? Because we know their kidney function is going to be pretty variable. It's going to change from day to day, even hour to hour in some cases. And so we have to make sure we're dosing our antibiotics appropriately. Because we know a lot of the antibiotics we're using for these patients tend to be nephrotoxic, right? A common combination you'll see for a septic patient, because even the patient comes in with sepsis, what bacteria are you normally treating for empirically? If you don't know what you're dealing with, you kind of go with the worst case scenario, right? So you're thinking about things like coverage for Pseudomonas, right? You're thinking about things for coverage like MRSA. So it means for MRSA, what are we using? Vancomycin, right? What are we using for Pseudomonas coverage? Aminoglycosides is a component, right? Remember, we double cover for Pseudomonas. Right, so that means we have something like an aminoglycoside plus a fluoroquinolone. Well, guess what? Fluoroquinolones are renally eliminated, right? You have to adjust for that. Your carbapenems have to be renally adjusted. Most of your penicillins have to be renally adjusted. So because of that, you have to look at all of that and make sure you're dosing appropriately, because otherwise you can see that toxicity develop. Okay. And again, no agent that we know actually treats the injury itself. All you can do is try to fix the insult or try to get rid of that, and then just manage the complications thereof. Okay, so some other cases we can try to help with treatment. So for instance, if we need something to get extra fluid off, we mentioned things like loop diuretics before. Another thing you actually use is an osmotic diuretic like mannitol. Mannitol has been used before to help provide extra osmolarity in the form of a carbohydrate, a sugar molecule. It's going to be too big for it to really be used for energy purposes, but it can help to draw fluid out of extracellular spaces. Right? You have to draw fluid off of places like the CNS and get rid of that extra fluid there. So it's very good for helping with those edematous conditions or in cases where we have a lot of fluid buildup happening here. You have to filter mannitol itself. I think I have a picture here in just a second. Let me see if I included that. Yeah, so that's what happens typically at less, say, colder than room temperatures, is you're going to find this mannitol crystallizes out. Anyone know like what temperature they normally like to keep hospitals? Is it pretty cold, pretty hot? Pretty cold, right? Because again, you want things like bacteria to be growing and all kinds of stuff. So normally hospitals are kept pretty cold. So you'll end up seeing a lot of this mannitol crystallizing out. If you pull that out, you can't use it, right? So oftentimes we'll have, I call it the easy bake oven. We'll have like a little box. We'll keep all of our mannitol and keep it at room temperature or slightly above room temperature to keep it like this. But you have to filter it, because what could happen if you had something like that crystallize out and get to the patient? Yeah, it can cause an embolism, right? So you don't want that to occur. So that's one of those things. I actually had a case where we use this a lot for like trauma patients. If you're thinking, if your patient's having cerebral swelling, it's good to draw fluid off of there because it's hyperosmotic. This one pharmacist told me it's back like probably like the early 90s or so, but they had a trauma patient come in and they needed to use mannitol for this patient. They're worried about herniation, and so all the mannitol they had was crystallized. And so he's like, "Oh no, we gotta get this stuff warmed up. What's the best way to warm this stuff up quickly?" Think about the microwave. Okay, let's go take it in the microwave. So you bring it over to the cafeteria, which is right next to the ER. Put it in the microwave. And what do you think happens to this nice glass vial when pressure builds up pretty precipitously in it? It's going to explode. So it exploded, of course, and ruined the microwave. He said, and I think this is apocryphal, but his badge had a big piece of glass in it that was protecting his heart. And I was like, oh, whatever, dude. But I was right, you do not want to microwave this stuff, but you do have to keep it warm because otherwise it will crystallize out. More often than not, loop diuretics will be used as well. This is, again, well tolerated, pretty good to help get that extra fluid off. Be careful, though, if you're using it consistently because it can cause ototoxicity if you're not able to clear it all that well. Okay. Again, torsemide can be used, bumetanide, any of those are fine. Ethacrynic acid is a good alternative if you have a patient with a true sulfa allergy. You may be cautious in using furosemide. Ethacrynic acid can be used as an alternative. So what would happen if you had, say, a diuretic resistance, right? If you remember, why do we get diuretic resistance? Think about, where do the loop diuretics work in the kidney? The loop of Henle, right? What happens, what occurred, or what part of the kidney is right after the loop? The distal convoluted tubule, right? So remember there, you'll find that by causing a lot of excess sodium being accumulated in the renal tubule due to the fact that the loop is not working effectively, all that extra sodium can potentially be reabsorbed at the proximal convoluted tubule, right? It tries to pick up the slack a little bit. And so you can see that you get this loop resistance. Also, when the kidneys are detecting that it's not really well perfused, what does it activate? The renin-angiotensin system, right? And again, that can also raise blood pressure. That can also help to underperfuse the kidneys as well. And so what you're going to find, you develop this loop resistance. And so very frequently ways to get around that is either, one, if you're using oral to begin with, switch over to parenteral therapy, right? We can try increasing our doses. Sometimes we can use continuous infusions, but more often than not, we're going to use an additional diuretic to help relieve that kind of that slack that the distal convoluted tubule is picking up, and then I can give a thiazide diuretic. So if you ever see someone who's, like, say, on furosemide and say a drug called metolazone, metolazone is a good thiazide diuretic I can use for patients that have poor kidney function. You may see hydrochlorothiazide. Any of those thiazide diuretics should be potentially used there. Okay. And again, kind of talked about the causes there, but again, it could be multifactorial, but those are the typical ways we'll try to get around that. Okay. So I mean, metolazone, again, as I mentioned, so one time a nephrologist said that metolazone can make a rock urinate. That's how effective it was. That's how I always remember that one's good for kidney patients who have a really poor GFR. Okay, so then what can we do for electrolyte management? Obviously, if they have hypernatremia and fluid retention, you're going to find that we can try doing things like limit the sodium intake. This is one way to do it. And then also, by doing that, it can lead to some of that loop diuretic failure, as you kind of mentioned, right? Because again, it's going to be losing some sodium there. But try to limit sodium intake. It's usually the easiest way to do it. And then we'll talk about the effects being kind of mitigated by the renal replacement therapy. That will pull off a lot of that extra electrolytes, like your potassium, like your sodium, and kind of help to normalize those out. Certain things, though, they can't really pull off that well. So like calcium is not really good for pulling that out. Magnesium is not really good for pulling that off. So some electrolytes can be corrected by RRT, but not all of them. Hyperkalemia is going to be another big thing you have to be considerate of as well. Anyone know how you treat hyperkalemia? We'll talk about this a little bit later, I think in the ER section, in the last section of class, but just to give you a little bit of a preview here, there's a good mnemonic I like to use to remember my therapy for hyperkalemia. It's called CA big K drop. I know, you're like, what the heck does that even mean? So I'm going to try to draw this out. And again, remember I'm left-handed, so this is CA, say big. I don't know, it looks like my daughter's probably drawing her letters. Big K, and then drop. Okay, so C is going to stand for calcium. Calcium chloride or gluconate is usually really good. It helps to stabilize the heart and prevents arrhythmias from occurring there. So calcium will be given. A, anyone know what A stands for? Albuterol actually stands for albuterol. By using a beta-2 agonist, that can actually help to drive potassium into the cells. A lot of what you're going to find with hyperkalemia is we're attempting to drive potassium into the cells in order to prevent it from having kind of negative effects on the heart. cause ventricular arrhythmia, right? So albuterol is a common one we'll use. Again, that's good if you don't have an IV therapy available. So say you just picked up a patient, say out in the field, you don't have IV access yet, you can give them albuterol, right? If you knew they were a dialysis patient, you knew they had missed their dialysis session, you're picking them up, you don't have IV access, like albuterol can be used in the short term. Now, B stands for bicarb, right? So bicarbonate can be used by alkalizing the blood. That again will help to drive potassium into the cells. Just like if you have someone who's acidotic, that will pull potassium out of the cells, alkalizing the blood will push it into the cell. Okay. And then anyone know what IG stands for? Insulin and glucose. I kind of alluded to that in the endocrine section. Insulin and glucose again will help to drive potassium into the cells. K stands for a drug called K-exolate. And that is basically either given orally or sometimes given rectally, and basically it's an exchange resin where it'll pick up potassium, it'll drop off sodium to the patient, and that can help to clear it. The big thing here with these is that notice they don't do anything to get rid of the potassium. Most of them are just shifting it, so it's a temporary fix to the problem. K-exolate can actually get rid of it, albeit slowly. And then the D stands for dialysis, right? So dialysis is going to be the main way to actually fix hyperkalemia. So you'll hook them up to dialysis, get rid of the extra potassium, and then the issue is fixed at that point. So anyways, that's a common group of drugs you're going to see used or therapies used to try to help to correct the hyperkalemia. But you can't see that in those acute kidney injury patients, especially if it's someone with chronic kidney disease and have an acute insult on top of that. That's where you run into big problems there. Okay. As I mentioned, phosphorus and magnesium are not removed by renal replacement therapy very effectively. And again, that can be a problem, especially with things like rhabdomyolysis, trauma, etc. You have to be careful because if the patient has too much calcium on board, you're going to find that calcium and phosphorus, they love to bind up together. And in fact, if you ever get an opportunity, mix a vial of calcium chloride or something with like sodium phosphate, and you'll see it precipitate out. It looks like a snowstorm in there. And so because of that, you don't want that to precipitate in your patient, because that can then happen all over the body. So we want to avoid calcium in those cases there. Okay. And then again, the other thing with renal replacement therapy is you actually have to worry about hypocalcemia. And so the reason for that is because whenever you take the blood out of the patient, what do you have to make sure the blood doesn't do? Clot off, right? Because again, once it gets exposed to all the plastic tubing and things like that, it wants to stimulate the coagulation cascade. So one thing we can actually do to prevent that, if you remember, if you go back to your clotting cascade, remember calcium was a very important sort of cofactor to helping to initiate activation of a lot of clotting factors. By giving a citrate anticoagulant, citrate will bind up calcium in the blood, prevent it from clotting, and then by the time it gets it back to the patient, then they're good to go. Well, the problem is all that calcium might be gone, so you have to replace that, right? So again, it's one thing to consider. Look at the calcium, make sure you're replacing that as needed for those patients there. And we'll talk about chronic kidney disease and all their issues with calcium a little bit later as well. Okay. So, any questions on that? All right. See, heads are spinning a little bit. That's okay. Let's do a 10-minute break. We'll come back and then talk about chronic kidney disease. All right. Any questions from the first half? I've commanded the room. No, any questions from the first half? Anything at all? All right. Just to try to keep you a little bit more engaged, again, I will open with another joke. This is an update to an oldie, but a good one. What is a pirate's favorite letter? Say R. No, it's not R. And then you say, it's the C. And I say, no, actually, it's P. Because without it, they would just be irate. Anyway. All right. So getting into chronic kidney disease, right? So this is chronic damage on the kidneys over a good long time. Normally this will be staged by their actual GFR calculation, right? So it's going to be, and again, there's different stages. I won't ask you questions on which stage are they based off their GFR, but just to give you an idea, obviously the lower the number is, this is not like golf, the worse it is, right? So you're going to find that when you get down to say something like, say 15 to 29, and you get less than that, this is when things are getting pretty severe here, right? And again, this is good because it kind of gives you an idea of some of the other sort of physiologic sequelae of having this chronic kidney disease, right? So we're going to see lots of issues popping up from this, including issues of, say bone homeostasis. We're going to see issues of, anemia is developing here because they're not developing certain hormones. Like we'll see all those kind of problems that develop here, right? So anyway. So let's look at some of the complications of chronic kidney disease. We know there's lots of blood and immune disorders that can happen from this. Typically, you'll have decreased cell-mediated immunity, so it tends to have worsened risk for infections you're going to see with these patients. Also consider if you have chronic kidney disease, right, and you're getting dialysis, say 3 times a week, you have to have a dialysis catheter in place or you have a fistula in place, and they're chronically accessing that a couple times a week. What could be a big risk by getting all these IV sticks? you're going to see infection, right? So again, infection is a common cause for some of these chronic kidney disease patients to be presenting like to the ER, to the hospital, are going to be for infection secondary to some of the stuff. You tend to see bleeding propensities. You tend to see platelet dysfunctions happen from this as well. You usually see platelet dysfunction secondary to that uremia that develops. From the endocrine standpoint, again, I mentioned hypoglycemia because what happens to the half-life of insulin when you have poor kidney function? It gets longer, right, because it can't be cleared out by the kidney. So you tend to find hypoglycemia could be a risk here. From a GI standpoint, you tend to see delayed gastric emptying, you see GI bleeding, again going back to the bleeding complications there, and you see things like neuropathies, etc. So a lot of different complications that can come about. Some of these we can help to manage, some of these we can't necessarily. But again, what's the common causes here? Diabetes is a big one, right? So if you can get patients' diabetes under control, usually the type 2 diabetic patients, you can help to decrease the nephropathies that occur from that, but certainly long-standing hypertension, glomerulonephritis, all kinds of different reasons for that, right? A lot of different risk factors for that as well. Now, we're going to find that you can find that basically what's happening here is you're going to have this loss of nephron mass over the long term. You have less, or actually going to have this glomerular capillary hypertension, right? That kind of goes along that long-standing hypertension. That increased pressure tends to kind of shred the glomeruli to make them less effective over time. They're going to be able to filter as well. That's where you can see, especially excretion of things like protein and glucose, etc. Especially as you kind of overwhelm the normal reabsorption sort of mechanisms you see there. And so, as you can see here, there is a lot of different factors that are going on here. You're going to see a lot of these tend to feed back on one another to kind of worsen the chronic kidney disease over time, right? So again, looking at things like having, say, an initial pathogenic injury, right? So sometimes these acute kidney injuries will develop into chronic kidney disease. You see glomerular injury, you're going to have less filtration happening here. And again, when you have less filtration happening at the kidney, remember the macula densa, they're sensing things like sodium, right? They're detecting pressure. When that goes down, what sort of responses will the kidneys have to that? The RAS system gets activated, right? The renin-angiotensin-aldosterone system, right? Because aldosterone helps us to hold on to what? Sodium, right? It's also going to stimulate ADH secretion. ADH helps us to hold on to water, right? So again, that's going to worsen things like hypertension, which again is going to cause further glomerular injury over time. You'll find that having that proteinuria is not going to be very good for the kidneys as well. So again, all these things happen to get this progression of disease. A lot of times things will then feed back on one another to kind of worsen the overall, right? So again, you have to arrest some of these other comorbid conditions to try to get things under control to try to prevent further progression of that kidney disease. Okay. So again, other issues that pop up here. So anemia of chronic kidney disease. So again, what is the main stimulus for producing new red blood cells? EPO, erythropoietin, right? And where does EPO come from? From the kidneys, right? So you have poor functioning kidneys, guess what? You're going to have less production of erythropoietin. So this is going to be a big problem. You're going to find normocytic anemia, right? Because it's not an issue of actually producing the red blood cells. There's just no signal to actually do so. And so again, this goes into the different therapies we're going to use to try to help manage these patients, right? So you're going to kind of keep all these different, kind of issues in mind as we go forward, and we get to the drugs. We'll talk about how to treat those. You're also going to find a lot of iron deficiency in these patients as well. Not only will they have kind of an increased need for iron, due to the fact that they're having to produce these red blood cells. You're going to find they will take less of it up in the GI tract. You're going to find they have frequent blood testing, so you're always having to check their labs. You're hooking them up to dialysis membrane. You're going to find that's not always going to be perfectly efficient getting all the blood back into the patient. So based on that, they have to have this increased erythropoietic stimulation because they need the red blood cells, and frequently it's going to deplete your iron stores. Okay, and if you're not absorbing enough from the GI tract, you're going to find this iron deficiency anemia that can develop as well. Okay, so very frequently you're going to find this also going to be playing a role as we need to make sure we're replacing iron. And again, anytime you're giving erythropoietin to help stimulate red blood cell production, you need to make sure a patient has good iron stores. Because I can give EPO all day long, but if they don't have good iron stores, is it going to really be all that helpful? Not really, because they can't produce that hemoglobin, right? So other issues you run into are going to be these mineral and bone related disorders. These chronic kidney disease patients develop what we call renal osteodystrophy in the long run. So we'll talk about the different ways that this occurs, but mainly this is going to be evidenced by things like hyperparathyroidism. You're going to find calcium and phosphorus are going to be out of whack. Usually these tend to either be elevated or decreased depending on which stage you're kind of fitting into, and we'll see where that comes into play. The calcium phosphate product is very important as well. So again, as I mentioned, as you're increasing your levels of calcium and phosphate, they like to bind to one another, and you can actually see precipitation occur here. Usually we'll be looking at something like a calcium phosphate product above 55 is when we're really worried about that precipitation occurring. It can be occurring in the soft tissue, it can occur anywhere, and that can lead to a lot of issues over time. We'll see bone turnover issues, soft tissue calcifications. Again, that goes back to the calcium phosphate here. And again, this will ultimately result in this renal osteodystrophy. And I'll kind of walk you through the steps here in just a second. But basically what happens is you have this decreased renal function, right? And then you'll have this increased phosphate levels, okay? So phosphate is not being cleared by the kidneys very effectively, so phosphate levels are going to go up, and then that will in turn bind up calcium. Binding up that calcium will lead to a hypocalcemia. So then, how does your body respond to hypocalcemia? The parathyroid is going to be the big thing that responds there, right? So it's okay, let's release more parathyroid hormone to try to get more calcium taken up from the bone, okay? It's also going to try to stimulate uptake from the GI tract, and it's going to try to prevent release of it from the kidneys. But you know the kidneys is not going to be a good spot there because it's not really working all that well. So anyway, so we're going to find that PTH not only increases calcium reabsorption, but also phosphate reabsorption, right? So you're getting both of those being increased in levels there. And again, that calcium mobilization from the bones an issue. So you're going to find that osteomalacia, osteoporosis that can develop over time. Not only that, but also what goes hand in hand with calcium? Vitamin D, right? Where does vitamin D get activated? And the kidneys, right? So if that's not functional, then you're going to find you don't have activated vitamin D, right? What do you call the activated form of vitamin D? Calcitriol. Some people say calcitriol, but it's that 125 dihydroxy vitamin D. Remember, you had that first step of activation occurs in the liver, and the second step occurs in the kidneys there. So patients with chronic kidney disease are not going to be able to produce enough of the activated form of vitamin D. That's also going to exacerbate their issues and increase levels of parathyroid hormone, right? Because remember, low vitamin D levels, low calcium levels are what stimulates the PTH to be released. So you're looking at this, you're going to find that there's some other cofactors here as well that are going to be playing a role here. But let's say we have impaired phosphate excretion. That's going to lead to more phosphate retention, which means it's going to bind up that calcium there, and that's where you see that calcium, calcification occur in the tissues. Okay, this will also lead to hypocalcemia, which will stimulate parathyroid secretion, right? And that's going to then lead to increased bone mobilization. It's going to lead to more calcium reabsorption from the kidneys there, and it's all going to lead to this osteitis fibrosis cystica, or that renal osteodystrophy that develops there. Okay. Not only that, but you have decreased vitamin D production, which means you're going to have impaired bone mineralization. The osteomalacia develops there, and again, renal osteodystrophy. So again, all these things kind of feed into each other, and they tend to worsen each other over time. So we're going to find some ways we can try to interrupt this process by either correcting levels of things, try to help to bind up things. So we'll look at some drugs that help with that in just a few minutes here. So as I mentioned, we get this parathyroid hyperplasia. A lot of that is due to that resistance to calcium and vitamin D therapy, because again, they're going to be deficient there. And we get the high bone turnover disease, right? So you get this more brittle bone. You're going to find you have a decreased erythropoiesis, because you have this bone marrow fibrosis that occurs here. So again, it's going to worsen the anemia. A lot of things tend to follow on top of one another and tend to worsen one another. Other things you're going to find are going to be these uremic symptoms. Typically, if you have uremia, you're just not going to be feeling very well. You have a lot of fatigue and weakness associated with that. You have itching kind of associated with that as well, you can see. And then these peripheral neuropathies that can develop. Obviously, you're going to be looking at things like edema, changing urine output. Typically, urine output is going to be going down. And then obviously, you'll see this foaming of the urine. So again, if they say, hey, my urine is really foaming, that's oftentimes a sign of proteinuria, right? Just like we talked about with like protein-based drugs, if you shake them up, what do? They foam up, right? So that's protein's basically coming out of solution there. Okay, so what do we want to do for these patients? One, we can try to delay and prevent further progression of chronic disease, right? So we can try to hold on to any kidney function we have. That'd be great. And we know any drugs that might help to prevent progression of kidney disease, especially for like a diabetic patient. ACE inhibitors, right? Those are nephroprotective, right? So we're talking about ACE inhibitors being a big role to play there. How are they nephroprotective? Because remember, what do ACE inhibitors do if you have a patient with chronic kidney disease and I give them full blast dose of ACE inhibitor? It's going to drop the kidney function acutely, remember? Because what does it do? It's going to dilate the efferent arteriole, right? Because it takes off that effect of ACE2 on the efferent arteriole, so it's going to dilate it, which can cause an acute decrease in GFR for patients with chronic kidney disease. But in the long term, if I can give it to them early, by having that decreased pressure on the glomerulus, the body will regulate to that. It'll get kind of get back to equilibrium. But you're going to find that decreased pressure is going to help to save the glomerulus. It won't stress it out as much over a long period of time, and that's why it's nephroprotective. That's why we like ACE inhibitors for those diabetic patients, especially because we know they're prone to that kidney disease. Okay. Other things, we have to minimize some of those complications. Hopefully, if we can, we'd like to limit the need for patients to either go to hemodialysis. And we know what PD stands for? So that's physical diagnosis. Peritoneal dialysis, which is a different form, which I picture what that looks like in a second, or transplant, right? So transplant would obviously be the ultimate thing you could do. But when you give them a kidney transplant, what do you have to do to them at that point to prevent them from rejecting the organ? You have to give them immunosuppression with corticosteroids and other immunosuppressants, and you have to worry about infection risk. So obviously, if we can try to prevent any of these big things, we'd like to if we can, and then address any of the primary causes. So whether it's hypertension, diabetes, etc., we'd like to fix that. So, and again, just to give you an example of the differences between hemodialysis and peritoneal, I'm sure you've seen this before or something similar. But basically, when you're using hemodialysis, you're taking the blood out of the patient, you're filtering it through the dialyzer, right, the membrane there, and then it will go right back into the patient. Normally, this is like a 4-hour process. Normally, they do it 3 times a week or so, depending on the patient, but that's basically what you're going to see there. A lot of them have a fistula. That way, they have kind of easier access for those patients there. Peritoneal, on the other hand, though, is going to be a much longer sort of process. Basically, you're going to be distilling a dialysate solution into the peritoneal space. Then, just based off of natural passive diffusion, you're going to find the waste products will diffuse into the peritoneal space, and that fluid, other stuff will diffuse from the dialysate into the patient, and then you'll then pull that out. And basically, you're making urine in the peritoneal space, right? So you're going to pull that out after those exchanges. So it'll go through exchange a couple times, and then that's their peritoneal dialysis, right? And so frequently, I see some patients who are on PD will come in and they'll actually have a peritoneal infection. We actually have to give antibiotics in their dialysate solution, and that way we make sure we get high concentrations right there where the actual infection is, which is kind of interesting. But that's kind of the main differences there. Normally, this is going to be something they can potentially do at home versus something they have to do like in a dialysis center or something. So anyway, so let's look at non-pharmacologic therapy for chronic kidney disease. One thing we like to do with the diet is at least to limit their protein intake. What does that do for us? What's high in protein? Phosphate is going to find a lot of phosphate in the protein there. So by doing that, and also we know they're going to develop proteinuria anyway, so that can help to try and limit that to some degree. Especially, if you think about it, if you have less than a GFR of 30, limit the protein to 0.8 grams per kilo per day. The flip side of that is a lot of these patients end up needing protein, right? They end up becoming, they have muscle wasting and things like that. That happens over time. So it's kind of a double-edged sword, right? You need them to have some protein, but not so much that it kind of exacerbates their kidney disease there. And then the other thing is to limit the sodium intake. Again, it's going to be helpful overall with the hypertension. It's going to be helpful to make sure they don't hold on to too much sodium, etc. And then obviously if they're smokers, get them off of that, help them to exercise, etc. So, as I mentioned, diabetic patients with chronic kidney disease, usually either ACE inhibitors or ARBs, should be used unless they have a severe contraindication, which most people are not going to have one. They should be receiving these. And again, don't give them full blast doses right out the bat. You want to titrate them up to see how they tolerate it, because we will see a decrease in kidney function if you give them full dose right away, assuming they have underlying kidney disease to begin with. Also, what electrolyte changes with the introduction of an ACE inhibitor? Potassium, right? Why is that potassium? Because the aldosterone is being not released as much, right? So you're inhibiting the activity of aldosterone. Normally, aldosterone will hold on to sodium in exchange for potassium, but if you get rid of that effect, you're going to be holding on to potassium instead. So you can't see hyperkalemia, and what is a problem with patients with chronic kidney disease? Hyperkalemia, right? So this could be a common cause where you want to look at the drug regimen for the patient to see if they've had any changes recently, and especially if they've been put on an ACE inhibitor or the dose has been adjusted. You got to watch the potassium levels, because those can go up and be potentially really problematic. Other things as well, metformin, as you remember, needs to be discontinued once you get down to a GFR less than 30 there, because otherwise you increase your risk for what? Lactic acidosis, right? Remember that if you can't clear the metformin, it doesn't produce lactic acid itself, but it helps to impair the liver from processing lactic acid. So again, some patients have died from this, so we have to make sure that once their kidney function gets down to a certain level, discontinue the metformin. Okay. And again, this is a big problem for a lot of chronic kidney disease patients, because people are not watching their kidney function for months and months at a time, and then they don't readjust their doses of the drugs, and then when they don't do that, then the levels get too high. This is where you run into problems here. Looking at the hypertension, obviously we'd like to target a blood pressure less than 140/90 there. Also, you're going to find that as you get the pressure down, that's going to help to limit how much protein and things like that you're filtering through the glomerulus, which is good. Obviously, if they're diabetics, and then ACE inhibitor, ARB is going to be kind of first line for them. Thiazides can be added on if that's not sufficient in and of itself. And then to kind of manage blood pressure based on their other comorbid conditions. So again, if they have a previous history of MI, what should they be on? Or if they have a history of CHF, what should they be on? Perhaps a beta blocker, right? You guys remember that? Beta blockers are going to be recommended for those patients, right? They should be on ACE inhibitors anyway, right, to help prevent some of that remodeling. So think about what else they should be on, and that will help to guide you to get the pressure under control, right? We don't really care how we get the pressure under control. We just want to get it down. And again, ACE inhibitors are good for those diabetic patients because we know it's going to help to limit kind of further progression of their loss of kidney function. Okay, looking at the anemia here, we're going to find that the goal here is we want to help to increase oxygen carrying capacity, right? So again, oftentimes that fatigue they're feeling could be uremia, or it could be related back to the fact that just their hemoglobin's in the tank, right? And so one of the big ways we can do this is, one, we can give them transfusions, right? But it's not the ideal way. We like to try to prevent that if we can, and instead try to help the patient stimulate their own erythropoiesis, right? So we can give them erythropoietin stimulating agents. There's the ESA, that's what that stands for, and then give them iron supplementation as well. Obviously, we're using the hemoglobin as our monitoring parameter. So the question is, what's a normal hemoglobin? So say for like a normal adult patient, what's kind of a general range for hemoglobin that's normal? 14, maybe 15, 16, somewhere around there, right? Kind of the high teens, mid to high teens, somewhere around there should be typical hemoglobin. Well, what would happen if I kind of stimulated a patient? Say, for instance, I have a chronic kidney disease patient and their hemoglobin's like 9, right? They're having symptoms of anemia. Now we're to stimulate them to try to get to a normal hemoglobin. What tends to happen is you're going to find that the blood becomes more viscous when you do this. And when blood becomes viscous, what does it do? It's going to clot somewhere, right? And where does it like to clot at? The brain's a big one I'm worried about, right? So there's actually been increase, and it can happen in the heart too. So there's increased risk of cardiovascular mortality and risk for stroke, usually ischemic strokes, right? Because you're kind of sludging up the works and not having good blood flow in these patients here. So there's actually a black box warning on these. You don't want to treat to a normal hemoglobin. You want to treat up to certain levels here. So for instance, once they get above 10, which would still be considered anemic in a lot of patients, you're going to find that by shooting up to a normal level, it's going to be too much for them, and that's where you increase that risk for stroke. So by getting up to like a level 10, maybe 11 in RRT patients. Now again, why do you think it'd be higher for a patient on dialysis? Because they're losing blood to blood sticks, they're having hooked up to the machine, they're losing some in the dialysis circuit. So again, they're going to be losing blood anyway, so you want to shoot for a little bit higher for them, just because you know they're going to be losing a little extra blood just due to the normal course of therapy there. And so again, that's why that black box warning is there to prevent that risk for stroke in those patients, okay? And again, if you don't correct the iron, you're not going to correct the hemoglobin. You have to get that fixed first. And again, we know there's less GI intake in these chronic kidney disease patients, so you want to make sure you're supplementing that. So the main ones you're going to run into as far as erythropoiesis stimulating agents includes epoetin alpha, they have epogen and procreate, and then it has darbepoetin, which is Aranesp. These are the two main ones you're going to run into. And again, as I mentioned, the black box warnings are going to be in those cases where death from MI, stroke, VTE is another risk as well when you try to get those hemoglobin levels up to normal levels. And again, if you think about it, if you think back to athletes who are using EPO in order to have better oxygen carrying capacity for these long endurance races, what do they frequently die from? Stroke, right? Because again, the blood's getting more viscous, and also when you're exercising vigorously, what happens to your intravascular volume status? You get a little dehydrated, right? And so again, it gets even more viscous and they stroke out. So it kind of makes sense, right? You can kind of link that back in your mind. Also, some risk for cancers here. So again, you could see some stimulation of some of these cancer types here. And the dosing, again, oftentimes you'll find patients, especially on dialysis, maybe getting it 3 times a week. So if they come in Monday, Wednesday, Friday for dialysis, they'll get Monday, Wednesday, Friday EPO along with that. Darbepoetin has a longer half-life, so you may only give that maybe once every 4 weeks or so. And again, adverse effects you're looking for include that thrombosis and also risk for hypertension, just because you're increasing that the blood volumes, getting a little bit more viscous, that tends to increase the pressure there. Okay, and then looking at the iron status, as I mentioned, you got to get this under control. You also want to make sure you're maintaining good levels of folic acid, B12, because again, some of this can be diminished by RRT. Also, and you want to keep everything in kind of good supplies there, so that way, when you have the EPO stimulating it, it's going to be able to get maximal production of that hemoglobin. And again, EPO tends to be very expensive because it is a protein we're having to make. So again, those are more expensive products. I don't want to be giving an expensive drug to a patient that's not going to work because they're not getting a good iron supplementation, right? It's just a waste of money at that point. Okay. Now you're going to find the oral intake of iron typically is not sufficient for a lot of these patients just because they don't have very good absorption. So frequently we may have to give IV administration of iron products, and we'll cover a few of those in just a second. So oral preparations of iron include ferrous sulfate, gluconate, and fumarate. There's a lot of other ones that are out there. There's carbonyl irons, iron polysaccharide. There's different varieties, but the main thing you want to look at when you're looking at these products is make sure you're taking into account the amount of elemental iron that are contained in these products here. Okay. And so again, because you can find that a normal dose of ferrous sulfate is going to vary wildly from ferrous gluconate, but it could have the same amount of elemental iron. All of it has to do with the actual salt form that it's in, whether it's a sulfate, a gluconate, or a fumarate. Okay. So again, most product packaging will express it as milligrams of elemental iron, and that's what you want to dose your stuff off of. Okay. Just to give you an example, if anyone's ever taken ferrous sulfate before, a standard adult dose is 325 milligrams. Well, when you actually convert that into elemental iron, it actually is only 65 milligrams of elemental iron. Okay, so again, if you were dosing it based off of that and say you're only looking at that 325, you may actually end up underdosing your patient because there's less elemental iron in there than what the actual tablet is. So again, make sure you're looking at that. And then there's some IV preparations for things like iron dextran, sodium ferric gluconate, iron sucrose, and ferromoxitol. I don't see this one too frequently. The more common ones I end up seeing are like the iron sucrose and the sodium ferric gluconate. Again, that's just anecdotal, is kind of what I've seen. So, what are some side effects of oral iron products? You know, constipation is a big one, right? So again, also you're going to find a lot of these CKD patients tend to have constipation anyway, but again, you're going to find that iron can exacerbate that. What does it do to the color of the stool? Turns it black, actually, right? So turn your stool black. Again, if you're thinking, okay, well, these patients have a bleeding risk, GI bleeds are a possibility. You see black stool, what do you think? GI bleed, right? I think upper GI bleed. And so again, you have to educate patients. Hey, this is not, when you see this, it's probably due to iron and not necessarily to the GI bleed. If you get that nice tarry kind of consistency to it, then you may be thinking more GI bleed. But again, it's just kind of a black discoloration due to iron oxidizing there. Anyway, so just be aware of that. Abdominal cramping, nausea, constipation, super common for a lot of these patients. Maybe reasons they say, hey, you know, they decide not to take it, or the case may be, and that way when they come in to get their EPO, you know, when your iron stores just aren't up to snuff, like what's going on here? It could be related back to the fact they just aren't taking the iron like they're supposed to, or they're just not absorbing it well enough. Now, the IV formulations, you have a different set of adverse reactions you see with this, and this can include things like allergic reactions, so you don't want to worry about that. And you can see hypotension, dizziness, headaches, so you want to infuse these fairly slowly. And again, sometimes these patients are going to have issues with their blood pressure anyway. Normally, they're set up so high that if you have any big drops, even down to a normal blood pressure, you know, 120/80, for them is not normal. It's hypotensive for them. They can still develop some of these CNS effects. You want to watch out for that. And then some arthralgias, arthritis, etc. You can see during the infusion. Okay, so how do you select an iron product? Obviously, oral is always going to be easier. It's cheaper. It's effective in some patients. You always want to go with that if you can. Most of the time, though, for our RT patients, because you're going to be sapping them of that hemoglobin through just the dialysis circuit and frequent lab draws and things like that, you're probably going to need IV products to help to kind of replete them. And then you're going to be monitoring iron status every 3 months or so while they're on ESA therapy, measuring hemoglobin at least every 3 months or monthly. In our RT patients, you're going to be seeing them pretty frequently anyway, so it's okay to go ahead and check them at least monthly. And then you'll do it a little bit more frequently on initiation, just to make sure you don't get them up too high. Because again, if you get the hemoglobin too high, you're about them stroking out, right? Okay. Now, getting back to the bone and the mineral disorders that happen here, so our goals would want to be to help to kind of stabilize the calcium and phosphate levels, so hopefully we can get PTH levels back down to somewhat normal and try to make sure we're not kind of demineralizing the bone too much, right? We don't have that rapid turnover disease that occurs there. Also, we're hoping not to get a bunch of extravascular calcifications, because again, that's not going to be good in the long run. And as I mentioned, normally we like to keep calcium and phosphate in the normal levels, but for a lot of them, you're not going to be able to do that. They're going to be elevated, but normally the level we're looking for is this product of 55. Once they get above that, then we know they're at bigger risk for the calcium and phosphate finding each other, binding up and causing those calcifications. Okay, and obviously you're going to be monitoring PTH levels as well. So what can we do for them from non-pharm therapy? Well, if we can decrease phosphate intake, the biggest way we can do this is going to be helping to decrease the amount of protein they're going to be taking in. And again, normally you're shooting for, say, like 800 to 1,000 milligrams a day of phosphate. Again, a lot of that's going to be coming in through the protein, so you have to be careful, because we know they need good supplementation, but you don't want to give them too much there. Okay. Other things to consider, telling them not to take are high phosphate foods and drinks. So things like beer, colas, peanut butter, things like that tend to be high in phosphates. You can find a list and educate them on that. And then dialysis patients, because they tend to be in this kind of hypercatabolic sort of state there, they typically have a little bit higher protein requirements anyway. So again, getting the phosphate under control may be tough. Okay. Some patients, though, actually can't get anything under control with just medications alone, end up having to get a parathyroidectomy. That could be another thing to consider. Okay, so let's look at things. So if we can't necessarily, say decrease the total amount of phosphate they have coming into the GI tract, maybe we can bind it up, right? Maybe we can bind up what's in the GI tract to prevent it from being absorbed. And so this is where we have our phosphate binders, okay? And so we have a couple here that are listed. Now, obviously, we said what binds up phosphate in the body? Calcium. So what if I can give it out in the GI tract? It's going to do the same thing there. It's going to be able to bind up that phosphate and then excrete it into the feces. And so a couple of these products here are going to be calcium-based, so things like calcium carbonate, which again, where do you find that at? Tums, right? It's a normal antacid anywhere, right? And again, cheap, available over the counter, you can find it anywhere, right? Another one's called calcium acetate, which is called Foslo, which makes sense. Phosphorus low tries to bind that up. These tend to be first-line products because, again, a lot of these patients are calcium deficient anyway, so if they get a little extra calcium intake, it's all going to be good for them, okay? Now, again, what does calcium do in the GI tract? What is a common side effect there? Constipation, right? So, again, if they're taking iron and then they're taking calcium, maybe they have chronic back pain on top of that and they're taking an opioid, you can see how the constipation can be a big issue for these patients, right? So you have to consider, hey, how often are they stooling? Do you need to add on some kind of bowel regimen, maybe some Go Lightly, some Miralax or something like that. Now, a couple other agents we have, maybe if patients cannot take calcium, maybe they're hypercalcemic to begin with, things like cevelum carbonate, things like lanthanum carbonate, and then aluminum hydroxide can all be used here, okay, potentially. One problem with aluminum hydroxide is that if you tend to accumulate aluminum, especially with this poor kidney function, it can lead to CNS toxicity. So this is not going to be recommended for a ton of patients, but maybe if they're not responding to maybe cevelum or lanthanum, this could be a good alternative to that, okay? But again, not our first line agent there. Anyone remember what aluminum hydroxide does in the GI tract? Remember, it's usually mixed with magnesium hydroxide. Magnesium causes diarrhea, so aluminum causes constipation, right? So again, think about all these different medications and what effects they're going to have on the GI tract. Okay, so as I mentioned, phosphate binders are going to be used pretty frequently to try to bind up any phosphate in the GI tract and help to eliminate that before it gets absorbed. Keep in mind, though, that if early on in chronic kidney disease, patients tend to be hypercalcemic, so in this case, calcium phosphate or calcium acetate or calcium carbonate are not going to be good options for those patients if they're already hypercalcemic. However, later on, you may find that it may be a good option, right? Especially if their hypo levels are pretty low there. Also, you want to make sure you're giving this prior to meals, because calcium carbonate gets more soluble in those acidic mediums. And again, when is your stomach producing the most acid? You start to smell that big juicy hamburger, right? Remember that the different stages of gastric stimulation, right? It's a cerebral one, right? It's the phallic one. That's when it helps to stimulate the acid production. That's when you want to start taking that stuff to help with the absorption. As I mentioned, cevelum is a good alternative if you don't want to use calcium here. It actually has some decent effects on lipids anyway as well. It can actually lower LDL and raise HDL. It's kind of a nice side effect. A lot of these patients may have comorbid hyperlipidemia potentially. And then again, just remember the aluminum is not used as frequently because we do worry about accumulation. We do worry about having CNS toxicity from that aluminum. Again, adverse effects, typically you're going to find a lot of constipation associated with these, hypercalcemia if you're taking a calcium-based one, and then I mentioned that aluminum toxicity, so watch out for those. The other big problem is that these patients are frequently on a ton of other medications to begin with. So imagine if you have your diabetic patient who develops chronic kidney disease and they start to get this hyperphosphatemia that you're trying to treat here. So again, if they're taking their metformin and their sulfonylurea and they're taking their ACE inhibitor and their hydrochlorothiazide, a lot of these drugs are going to be bound up by these calcium-based products here. Not only that, but also remember the iron will like to bind up with calcium too, so you can find a lot of drug interactions here, drug-food interactions. So you have to be careful there, right? Think about things like fluoroquinolones. If they needed to treat an infection, that's going to get bound up by those as well. So you need to separate, either give the drugs an hour before you give the calcium-based products, or give it 3 hours afterwards. We mentioned with vitamin D therapy, typically ergo and cholecalciferol are not going to be sufficient because the kidneys are not functioning well enough to actually produce the 125 dihydroxyvitamin D or the calcitriol. So because of that, we would just give calcitriol directly. Okay, so if you ever see that, it's normally because the patient has poor kidney function, can't produce them themselves. This is good because it'll suppress that PTH function. It'll help to deal with some of that bone turnover we were worried about previously. It helps. Can lead to a little bit more hypercalcemia, hyperphosphatemia. So that's one thing you don't want to worry about. And again, you're just going to be monitoring levels for these patients in these cases here. There's one we can use that kind of gets around this hypercalcemia, hyperphosphatemia. It's called pericalcitol, and basically it will activate the PTH receptors and make it think there's enough vitamin D, but actually doesn't have the same activity as vitamin D, so it'll actually have neutral levels there. So this would be a good drug as an alternative. Say, for instance, say like on a test question or something, you had a patient who is hypercalcemic, hyperphosphatemic, but their PTH levels were elevated. You could give something like pericalcitol as an alternative to calcitriol to get PTH levels down, and it won't really have any effect on the calcium and phosphate levels. It won't worsen those. Okay, something to think about. Cinacalcet's another drug that actually will sensitize the PTH receptors to the effects of calcium, and that can also be useful to help use the calcium levels that are already there to help reduce those PTH levels as well and decrease some of the bone turnover. Okay, so any questions on that so far? Okay, let's look at drug-induced kidney injury. Getting back specifically into the drugs here. So what are some manifestations of drug-induced kidney injury? Well, we have things like acid-base abnormalities that could be occurring here. We talked about electrolyte abnormalities that can happen. This can be evidenced by things like hyperkalemia. It could be evidenced by hypomagnesemia. Say you're losing a lot of magnesium in the kidneys due to interstitial injury. Lots of different things can happen here. But the most common thing you're going to run into is decreased GFR. And again, what do you need to calculate GFR to measure that? Serum creatinine. Remember, it takes time for the serum creatinine to adjust. Again, urine output is also going to be another big thing you're really looking for with these patients. So we know that a lot of community-acquired drug-induced kidney injury, about 20% of those patients that are admitted for acute kidney injury are due to drugs, whether it be NSAIDs, ACE inhibitors, loop diuretics, any of these drugs here, you have to be careful of. In the hospital, though, the majority of the acute kidney injury we're actually causing in patients is due to the medications, right? So a lot of antibiotics, chemotherapeutic agents, antivirals like acyclovir, etc. So we know that we're initiating a lot of these drugs here, and we just have to monitor for that decrease in kidney function. So as I mentioned, the most common thing you're going to see is decline in GFR. You'll see a rise in serum creatinine and BUN. However, you may find that the tubular function, you may find reduced tubular function without actual loss in GFR. And so what I mean by that is you may find that the kidneys are still able to process creatinine effectively, but it doesn't really resorb or secrete things like it normally should. And so someone kind of described it as the kidneys are acting kind of dumb, right? So again, it is not able to manage things like glucose or electrolyte reabsorption and things like that effectively. And so even though the GFR looks okay, they're still losing a ton of magnesium in the urine. They're losing a ton of glucose or protein, things like that. So again, you can't just use the GFR by itself. You have to kind of coordinate with a lot of other points of data there, okay? So again, obviously the signs we're looking for include things like decreased urine output. We're looking at things like hypertension, volume overload. When I say CIN, that stands for contrast-induced nephropathy. So it's some of those contrast dyes we use for imaging studies. NSAIDs and ACE inhibitors, these are all likely to cause these kind of hallmark signs you see there. And then if you have proximal tubular injury, usually it's going to be an issue of you're developing a metabolic acidosis, because remember, in the renal tubule, where do you reabsorb most of your bicarb? Yeah, I mean, where do you resorb most of everything? In the proximal convoluted tubule, right? So that's a safe answer. So in those cases there, you're not reabsorbing bicarb effectively, so you're losing it in the urine, and so that develops a metabolic acidosis, right? So these are other things we can be looking for, hypophosphatemia, hypokalemia, hypomagnesemia. If you have someone who's on like amphotericin B, this is frequently what you end up seeing, is that they just cannot reabsorb things effectively, and so they just excrete a ton of stuff that they really shouldn't be, and so that's where you get those dumb kidneys, so to speak, right? With distal injury, this is going to be more of an issue of concentrating the urine effectively. So you may see things like polyuria because you're not able to either use things like vasopressin effectively, antidiuretic hormone. Hyperkalemia you're going to see pretty frequently due to this, because maybe aldosterone is not working as effectively. So there's a lot of issues that are going to be happening here. So just to give you an idea of some drugs that can cause acute tubular necrosis, some of the common ones you may run into include things like aminoglycosides. Okay. Radiographic contrast media. Some of these I'm going to get into more detail in just a little bit. In some ways we can get around it. If you work in hemonc, you see cisplatin and carboplatin, right? Remember those alkylating agents cause a lot of kidney injury. There's another thing you're going to see there. Amphotericin B, if you're dealing you work in the ICU or work in infectious disease and you see a lot of invasive fungal infections, that's going to be used there pretty commonly. Anyone know what you use cyclosporin and tacrolimus for? These are immunosuppressants. Sometimes they're used in autoimmune diseases like, say, ulcerative colitis or Crohn's. Oftentimes they're used as immunosuppressants for organ transplant. So you might see them in solid organ transplant or bone marrow transplant. You have things like cidofovir, tenofovir. Those are all antiviral agents, obviously. And those are more common ones you're going to run into, right? You can see things like osmotic nephrosis. This can happen with like highly osmotic agents like mannitol, IV immune globulin. You can see this occasionally. And then things like hemodynamically mediated kidney injury. This is going to be more of those pre-renal sort of kidney injuries, and that includes things like ACE inhibitors, ARBs, and your NSAIDs. Some things can cause more of an intratubular sort of obstruction. And as I mentioned, acyclovir is a very common one that we mentioned, where if you don't hydrate the patients well, they can see that acyclovir precipitate out and cause some obstructive sort of issues there. But some other ones here you may notice. Methotrexate is another big one. If you work with HEMONC and you're dealing with really big doses of methotrexate, that's why we give it with bicarb. It helps to keep it solubilized, helps to prevent it from precipitating out. And then some things can cause nephrolithiasis, sulfonamides, tramtrine, just a few options there. So again, the variety of kidney injury can be very different depending on the type of drug. Some of it makes intuitive sense based on the mechanism, some of it not so much, right? Like an ACE inhibitor makes sense why it causes kidney injury, but something like, acyclovir, you just have to know the chemical properties of it, that it likes to precipitate out when the patient's dehydrated. Some other things like glomerular disease. Anyone remember where we use gold at? Or just where they have patients with like good insurance? No, it was an immunosuppressive, right? So we used it for autoimmune conditions like, inflammatory bowel disease way back in the past, or rheumatoid arthritis. We don't use it anymore. But like lithium's another big one you have to worry about. We'll talk about lithium specifically when we get into things like diabetes insipidus a little bit later, NSAIDs. And then some cases it could be an allergic reaction. You're actually having a nephritis that develops from the kind of IgE-mediated immune response to things like penicillins. And again, my goal here is not to have you memorize this entire list specifically, right? I just want to give you an example of the different ways in which these drugs can cause kidney injury. Now, when I get into specific examples here in just a little bit, those are the things I want you to know. Again, I'm just kind of showing you there's a wide variety of things. And whenever you have a patient with kidney injury, you always want to go back and look at the med list, right? Because there could be something there that you may be overlooking. Even though it may not be common, it could be present in your patient, right? Okay, so again, how does this occur? In some cases, you may find that the drugs themselves can cause direct cellular injury or ischemia, right? Some of it may be related to volume issues like NSAIDs or loop diuretics, but in some cases, especially aminoglycosides, they're going to cause direct cellular injury to that tissue there. And so that's where we're going to find things like apoptosis, cellular degeneration. That's where you see a sloughing of those cells. That's where you see things like casts and whatnot in the urinalysis a little bit later on. Now, as I mentioned, you're going to find acute tubular necrosis is the most common presentation of drug-induced kidney injury in the inpatient setting. As I mentioned, aminoglycosides are probably the #1 thing you're going to run into causing this, followed by things like radiocontrast media and cisplatin. Again, amphotericin B is going to be much more on a special case-by-case basis for those patients with really invasive fungal infections, but probably these three are the most common ones you're going to run into. Yeah. As I mentioned, aminoglycosides, you're going to find that 10 to 25% of your patients coming to the hospital end up getting aminoglycoside for infection, right? Because it's a great gram-negative killer. So we give it to a lot of people there, especially in the critically ill patients who are most at risk for drug-induced kidney injury. They're going to be getting these drugs here. So what do you think are some ways we can try to make sure that patients don't develop kidney injury from aminoglycosides? Remember anything where maybe we could use like drug levels potentially? Remember that therapeutic drug monitoring we talked about before? This is going to be the case where you're using a lot of monitoring to make sure, drug levels specifically, to make sure that the levels are not building up too high, because we know if the drug is sticking around, we know it's going to be able to build up levels in the kidney, and we know it's going to cause direct injury there, okay? And again, we're going to notice this, say 5 to 10 days after therapy starts, and we're going to see this increase in BUN, creatinine is going to go up, we'll see urine output start to go down, usually you'll see that first, and then you're going to generally find that if it's caught early and the drug is discontinued, or the levels are adjusted effectively, you're going to find that is going to lead to reversible function in the kidney. In some cases, though, it may not be so much. And so what we're going to find is that a lot of this is due to these kind of chronically high levels, this accumulation of aminoglycosides within the renal tubules, right? And you find they would develop these reactive oxygen species, kill off all these cells in the renal tubules, and cause a lot of havoc there. And so what they found was the risk factor was the bigger the dose you're receiving, the more prolonged therapy you had, and these trough concentrations greater than 2 micrograms per ml. Okay. So how do you think we could get around that based on that trough concentration issue? Well, we could try to shoot for lower troughs. And if you remember back in the day, and again, you think back to those days when I talked about like concentration versus time dependent, this is actually one of those cases where it actually matters, and you think it would never come up, it actually does. If you remember, aminoglycosides, were they time dependent or concentration dependent? They were concentration dependent, right? I can shoot for a much higher dose and get that nice post-antibiotic effect, right? So to give you an idea, here's what we used to do. If I can get back to, where's my mouse at? Here it is.
Okay, so imagine, back in the day, what we used to do when we were dosing aminoglycosides is basically give a dose every 8 hours. So you see this level here, and you give another dose, another dose, another dose, right? And so what you intend to find is when you have these levels staying above a certain point, you tend to accumulate. So what would happen with a patient who maybe started to develop some of this nephrotoxicity, let's say they have this green line now, you're going to see that, yeah, they start at the same levels here, but then they don't really eliminate it quite as well. So then see it start to go up. And so the more accumulation you saw of the aminoglycoside, you found that you were more likely to see more kidney injury occur, and it's kind of this self-repeating cycle, right? So the worse the kidney function was, the more drug you held on to, the more kidney injury occurred, the more you held on to, etc. Okay, so what are some ways to get around that? Well, actually, we changed the entire way we dose these drugs for the most part nowadays. Instead, what we do, and I use this light blue line, is we use Q 24-hour dosing. And so what that does is, because we know we have the post-antibiotic effect, we'll shoot for a really high level here. Again, I'm going to obscure my own writing, but the really high level here, and then we'll let it get down to basically 0. Okay, and then the next 24 hours comes up, and we'll dose it again, really high levels, and get down. So the benefit here is, for the most part of the day, that level is 0. That means you're not accumulating any drug, none of it's building up in the renal cells, and you're going to find they don't cause that same damage. So again, this is where looking at different dosing strategies can actually help to mitigate how often we are going to have these cases of drug-induced kidney injury. And this is why therapeutic drug monitoring is so important for some of these drugs here, like vancomycin, like aminoglycosides, etc. Right? Now, again, in the hospital, do you know who's doing most of this monitoring? Usually, actually, the pharmacist, right? So again, especially in big hospitals where you have protocols set up to where actually we'll do all the monitoring for this. You can just say consult pharmacy to dose aminoglycosides, and then we just take care of it for you, right? However, you may not be working in a place like that. You may be working in a smaller hospital or something like that where you have to do it yourself. And so again, this is why you want to have a rationale for why I'm looking for certain levels or why I'm shooting for certain strategies as far as dosing goes, etc. Okay, so that kind of makes sense. So we shoot for bigger doses, get the level down to 0, and then you don't see any of that accumulation.
So if it's concentration dependent and you're at 0 for most of the day, wouldn't that make it less effective?
Because remember, we had the post-antibiotic effect. Right, so for something like vancomycin, which is a time dependent, we have to keep the troughs above a certain level. Even though we know that vancomycin can cause nephrotoxicity, we have to make sure we keep a certain trough anyway to be above the MIC, if you remember. So in those cases there, we just have to make sure we're monitoring the trough effectively, make sure it's not building up over time. And say we're shooting for, say, a level 15, we want to make sure we don't get to a level 40, a trough of 40, and oh no, we have too much, and now we have this kidney injury here. Okay. So anyway, so as I mentioned, be very kind of judicious in who you're going to be using your aminoglycosides in. That would be the first thing, right? They're really prone to kidney injury. If you can get away with not using it, that's going to be an effective tool. And then try to limit concurrent nephrotoxin use. So if I can limit how much loop diuretics I'm having to give along with it, if I can limit how much vancomycin I'm giving along with it, if I can limit vasopressor use like norepinephrine or epinephrine along with that, that's all going to be able to help limit that nephrotoxicity because they tend to be kind of synergistic with one another. Okay, and then that's where we're going to do the prospective pharmacokinetic monitoring. We're actually monitoring drug levels, making sure they get down to certain levels, certain gold troughs or levels, and that way we're not going to be accumulating the dose there. Okay. Obviously, if you saw aminoglycoside-related kidney injury, the ideal thing would be just to take it off altogether, right? In some cases you can do that. In some cases it can be kind of tough depending on the infection you're trying to treat, but that's the ideal thing. Now, looking at something like radiographic contrast mediated nephrotoxicity, or that CIN, contrast-induced nephropathy, this is something that's probably on the decline over the past decade or so, mainly due to the fact that we're using contrast agents that have a lower osmolarity. Basically, the stuff we were using before is very hyperosmolar and caused a lot of fluid shifts, especially in the renal tubules, and caused a lot of injury in those cases there. And it was tough because, think about it, you have a patient who comes in to the ER, they're complaining of chest pain, and you want to rule out, say, something like a PE. What kind of test can you use to rule out for a PE? CT scan, right? So again, you want to make sure you're looking at things like renal function before you send them to the CT scan. Because otherwise, if you were to give them this contrast potentially, and didn't realize they were on metformin and realize that their GFR is like 20, you'd induce a lot of kidney injury for those patients. So this is one of those things where a lot of prospective laboratory monitoring before they go to the imaging, and it can be very useful to prevent this. But you find this a lot, especially in these chronic kidney disease patients, where they would have kind of an acute injury on top of their chronic injury due to this contrast and die. It can typically be like a 24 to 40 hours after administration. So say that patient came in, they have long-standing chronic kidney disease, you gave them the contrast, came back, they don't have this PE, they look good, you're going to say, I'm going to go and send you on home. And then they had the injury on top of that, say 24, 40 hours later, then they're right back, right, with the worsened kidney function. So sometimes these are things that may not present initially, but you have to monitor and make sure you're aware of who might be at biggest risk. And so one of the biggest things we did to try to prevent prevent this was actually either using agents that have lower osmolarity. So you see here, the old agents we used to use were, say, 600 to 2,000 milliosmoles per kilo. And we said our blood is what? Around 300, right? 280 to 300. So again, this is very hyperosmolar, cause a lot of injury there to the tissue. So now we use lower osmolarity agents. We also hydrate very vigorously before they go, if possible, try to make sure they're not going to be try to dilute out that contrast as much as we can, so it doesn't cause much injury there. So again, try to minimize the dose we can use if possible. Try to use non-iodinated contrast agents that can actually help out as well, and then use either lower isoosmolar contrast agents. So that's kind of the big thing we've switched to use nowadays to try to prevent a lot of that injury. But it still can occur. You still want to be aware of it happening there, and obviously avoiding concomitant nephrotoxins. If you can, you want to halt things like metformin for like a day or two beforehand, because you know that can be also playing a role as well. And then we'll be giving isotonic crystalloids usually 3 to 12 hours prior. And we try to tank up the patient as much as we can, try to dilute out that contrast as well as you can. But again, if you need an emergent scan, you need an emergent scan. So in those cases, if you can get away with using dye, that's beneficial, but sometimes you have to. Okay. Some people try using things like sodium bicarb. Some people try using things like mucomist, but for the most part, just hydrating the patient well and avoiding any concomitant nephrotoxins is the best thing to try to avoid that contrast-induced nephropathy. Okay. I have a couple more minutes. I can get through a few more things. Let's look at patients with chemotherapy, right? So if they're receiving cisplatin for any particular type of tumor here, you'll see this is used for a lot of solid tumors. You're going to find that the major dose limiting thing for cisplatin is going to be nephrotoxicity. And again, just like we said, the chemotherapy drugs for the most part are not very selective for cancer cells versus our healthy cells. And so same thing goes with the kidneys as well. And so in these cases here, you're going to find that when they injure the kidneys, you're going to find that they will impair that tubular reabsorption and decrease the ability for the urine to concentrate. So the things you'll find are going to be things like polyuria, decreased GFR. You're going to find a lot of electrolyte wasting as well, right? Because they're damaging all those interstitial cells there in the renal tubules. And so what do you think are the best way we can try to do to prevent this? Well, hydration is going to be one of the best things, right? If we can flush that stuff through as best as we can, and you'll frequently find that patients will be on 2-3 times normal maintenance rates, just to try to flush the patient, keep them repleted as best you can to get that drug out of there, right? Most of the patients will probably have decent kidney function, and so by again giving them vigorous hydration, you can try to prevent that cisplatin from sticking around and preventing any injury as best you can. So as I mentioned, we'll see pretty vigorous hydration with NS, usually 12 to 24 hours beforehand. You want to limit any other concurrent nephrotoxins if possible. And if you need to, for really high-risk patients, we have a drug here called amifostine or ethoyl, which is actually a chelating agent. And what it'll do is actually preferentially chelate cisplatin in these normal cells here, and will allow it to kind of save or spare the renal cells while still having efficacy against the cancer cells. So again, it's really going to be reserved just for those really high-risk patients there, and because it's expensive, and normally fluids are going to be good enough for most of them anyway. And obviously treatment, generally it's going to be supportive for the majority of things here. Sometimes you may need renal replacement therapy and then just replace the electrolytes as needed, because you're going to be losing things like potassium, you're going to be losing magnesium. Just replace those as you need to. Okay, so I'm going to go ahead and stop here. We'll continue talking about that later. Let me look at the